Good afternoon again. It's 4:03 going into 4:04. I think we should proceed and start given the interest of time. Welcome to another Botswana COVID webinar series. My name is Dr. Palai. I'm a fellow in pulmonology and critical care with the University of Botswana. We are privileged today to have a colleague who's heavily involved with COVID-19, a WHO a consultant. As usual, we start off with the introductory slides, and then I will duly introduce our guest speaker. Okay. As usual, we have our house rules. This webinar series is organized by Ministry of Health and Wellness, University of Botswana, and Botswana-Harvard partnership with the anchor being Rutgers University. They've been running this webinar series since last year with Dr. Gaolathe also assisting. So you can join the mailing list by emailing Vusi, who's a tele-moderator on these webinars at vindaba at globalhealth.rutgers.edu. Again, vindaba at globalhealth.rutgers.edu. The sessions are over Zoom, as you can see. And please, during these sessions, mute your mics. You will have an opportunity for a Q&A at the end, which is why it will be important for us to keep to time. Questions, but you have the opportunity to actually ask questions on the chat function as well. So these webinar series are actually recorded and they're available on YouTube as Botswana-Rutgers Partnership for Health. If you go on YouTube and you search for that on the Echo, you'll find that you've got all these webinar series since last year. This one will be recorded and made available as well. Next slide. So this is a very, very important website for the clinicians and healthcare workers in Botswana, covid19portal.gov.bw. It offers really a majority of the information with regards to COVID-19. But if you click on the document library, as you can see, those options available, you'll see that there's lots of guidelines. Next slide. From clicking on the document library. There's guidelines on how to open up a center. There's guidelines on clinical management in pediatrics, clinical management in adults, COVID-19, clinical management even in pregnant women, as well as what to do in terms of advising businesses within your districts. Please make use of it. Next slide. And then finally, today we'll be talking about mechanical ventilation, COVID-19. We are privileged to get an opportunity from Dr. Munsaka, Effraim Munsaka, who is an anesthetist and critical care specialist registered with the College of South Africa, College of Anesthesia in South Africa. Dr. Munsaka has been heavily involved in COVID-19. He's practicing in Odagwa Private Hospital, and is really the lead critical care specialist for the COVID-19 response. His interests include information technology and innovation in ICU, which is really the new kid on the block. Things like cardiac monitoring and all that. And it's mainly around actually data collection and using that change and how we can practice and actually make ICU care better. He's going to experiences in mechanically ventilated patients in COVID-19 and give his opinion on whether we're getting it right. We welcome you, Dr. Munsaka. Off you go. Doc, you can actually click on the slideshow button at the bottom so that the slides are bigger.
Okay.
Yeah, thanks.
I'd like to thank the Ministry of Health and Wellness in Botswana, the partners, including the University of Botswana and Botswana-Rutgers partnership, for inviting me to participate in these webinars. The topic I'm presenting today is a topic that is of interest to me as regards how we can better manage ventilated patients in ICU, especially with regards to COVID-19. Vusi, how do I just go on with the slideshow? Okay, I'll just let you know to go to the next slide. These presentations, the views in this presentation are my own, and it relates mostly to the practice or the experience I've had with managing COVID patients. And when I was preparing this presentation, my target audience was the hospital managers, the residents, the medical officers, and the nurses that are involved in managing these critically ill COVID patients. And how we can better appreciate the challenges we face when we are ventilating these patients, why it's so difficult to get them around, and why possibly we are seeing a bit of outcomes that are not yet favorable. Next slide. Okay, so the interesting question I had was that why are mortalities with mechanically ventilated patients so high? I think there's been some ICUs that are reporting almost 100% mortalities in these patients, begging the question: is it that the ventilation itself is causing the mortalities, or are we doing it right when we're doing that? And this is one example of a meta-analysis that was published earlier this year, looking at the case fatality rate on ventilation. This meta-analysis reported a case fatality rate of about 45%. Which I think, from the experience of the ICUs I've been to, it gives me an interesting question. So why are others having a relatively higher mortality compared to what is reported in the literature? So this meta-analysis looked at 69 studies with over 57,000 adult patients that were mechanically ventilated patients. Next slide. So briefly, as an introduction, we receive these patients in ICU classified as either severe COVID pneumonia or in a critical state of COVID pneumonia. This is according to the WHO classification. And the primary reason would essentially be the hypoxia that these patients have in the ward or wherever they are being transferred from. They'll be classified as, they'll be described as having an acute hypoxic respiratory failure. And inadvertently, most of the patients that will receive in hospitals, about 15 to 30%, will progress into severe COVID pneumonia, or inadvertently could proceed to critical COVID pneumonia, necessitating the need for intubation and ventilation, after exhausting the various modalities that we explore before we reach that step. Next slide. Okay, so just to kick off, I thought it would be best to start off with a bit of an introduction. A bit of respiratory physiology, as we think around oxygenation, and as we also think about intubating these patients in the hope that we can better oxygenate them. The causes of reduced oxygenation in this patient is essentially a mismatch between perfusion and ventilation. And in respiratory physiology terms, alveoli that are perfused but not ventilated, we call it a shunt. Okay, and on the extreme end, it will be alveoli that are ventilated, but then there's poor perfusion. So both of these extreme ends tend to cause poor oxygenation of the blood, and hence we pick up the hypoxia that we see in disease processes. So normally in a lung, there's a reasonable distribution of all of these factors. Essentially here in this picture, in zone 1, we typically tend to have more of a well-ventilated alveoli, but poorly perfused. In the middle zone here, this is where we have a kind of a bit of a good balance. Right at the bottom in the lower zone, you have very well perfused alveoli, but may be poorly ventilated. So these extremes, this extreme will essentially describe more of a shunt, and the other extreme will present more with an alveoli dead space. However, physiologically, there's a way that physiologically the body will try and maintain good perfusion to give a normal individual a good saturation and perfusion of organs. And in a disease process, this balance is offset, either shifting towards a shunt. The shunt itself will be more what we describe as the right to left shunt. And the dead space will typically be described as a well-ventilated alveoli that is poorly perfused. Okay, next slide. Okay, so this is just a microscopic section of a dog lung, giving a more or less a clear picture on how the alveoli will typically look, and then how the capillaries around, how the dark spots will be your red blood cells, how they move around in capillaries, and the clear spaces are the alveoli. And in disease processes like COVID pneumonia, the interface between the alveoli and the capillary space is what initially will be affected. It gets inflamed, it gets edematous, making it difficult for oxygen to move from the alveoli into the capillaries to provide adequate oxygenation for patients or for any individual. And normally the alveolar capillary membrane is described as having a width or a length or whatever modality you use as 3.4 micrometers. So in an infective process, this is widened, making oxygenation a bit of a challenge when an individual is sick. Okay, and this will appear as an increase in the alveoli arterial gradient. The inspired fraction of oxygen, there'll be a big disparity between what will ideally be measured in the alveoli and what will be measured in the capillaries or in the arterial circulation downstream. Next slide. Okay, just next slide again, Vusi. Okay, so that was briefly about the physiology, and carrying these concepts of a shunt and also carrying the concept of a alveolar dead space. I wanted to bring it home with COVID. Okay, so for susceptible patients, COVID, the SARS-CoV-2 virus tends to cause a very intense inflammatory picture right off at the beginning, okay? Stimulating the immune system for macrophages to come in to try and limit the damage as a result of the infective process. As a result, there's release of several chemicals to try and produce a reasonable amount of a pro-inflammatory phase, including cytokines, chemokines, and other reactive oxygen species. However, if this is not, again, corrected by the body, it will initially affect the fewer alveoli where the virus is. Beyond that, if the pro-inflammatory phase is intense, it also affects other areas of the lung, other normal areas of the lung, worsening the boundary, the alveolar capillary membrane, this segment of the lung, increasing its width, making it difficult for transfer of oxygen from the alveoli into the capillaries, and hence the desaturation we tend to see with COVID patients. If a reasonable amount of lung is affected, patients will present with what is described as ARDS, or an acute respiratory distress syndrome. If the inflammatory phase goes way beyond that, causing damage to other organ systems, it causes a picture that is described as sepsis. So those are two concepts we'll also carry, but I'll kind of focus mostly on the respiratory system and how it is affected and why we tend to see considerable amounts of desaturation in these patients. Next slide. Okay. So focusing on the lungs, so in these lungs, again, right from the beginning, we have a shunt that will ideally, when the inflammation causes an increase in the alveolar capillary membrane width, there's edema around that area because of the inflammation and trying to limit the infective process. That will cause more or less a reasonable amount of shunt, because that area will be poorly ventilated, or will be ventilated, but there'll be a poor flow of oxygen from alveoli into the capillary space. And that will kind of give a shunt picture, or a right to left shunt, reducing the amount of oxygen that is transported. And there'll be very, with the increase in terms of the inflammatory process, there'll be very little lung available for oxygenation. And this amount of lung that will remain, because the patient will already have started desaturating, is the area of lung that we try and target in terms of ventilation as we kind of increase the oxygenation of these patients. Next slide. So it will affect the lungs, and then compounding to that is the effect on the pulmonary circulation. As a mechanistic process, the current thinking is that the disease progression in COVID will initially be more of an immune hyperactivity. I can remember I did mention that it's the intense inflammatory process that affects the alveolar capillary interface that reduces the amount of oxygen transfer and kind of a shunt mechanism, poorly oxygenating the blood, and then which we end up picking up as a low saturation or hypoxia. So that intense inflammatory process, or the immune hyperactivity, is what is currently thought or is currently described as a cytokine, as an effect of a cytokine storm. However, that inflammatory process is also countered by the body's response to try and reduce the inflammatory process. So the initial process is quite an intense pro-inflammatory phase. Then that pro-inflammatory phase tends to damage the lungs, tends to cause the hypoxia, and also tends to damage other parts of the body that we see in what will eventually be in critical COVID, will be a picture of sepsis and organ dysfunction. And also the other thinking is that the inability of the body to resolve this process by an anti-inflammatory phase is what tends to make these patients deteriorate in terms of the progression of the disease. Next slide. Okay, So we're carrying, we again with me the idea of a shunt and also the idea of an alveolar date space. With this, there's an observational study that was done last year in July in Cape Town. They looked at 14 patients with COVID pneumonia. They were doing flexible fiber optic bronchoscopy for diagnostic and also for therapeutic purposes. They observed that 9 out of the 14 patients they had a look at, after having an average of 7.7 days of mechanical ventilation, these patients, when they did a bronchoscopy, they found that they had extensive mucus plugging. Okay, so giving a picture of what is described as organized pneumonia. I'll kind of a little bit focus on the mucus plugging and also refer it back to the idea of the alveoli being ventilated and the alveoli again being perfused. So the significant amount of mucus plugging that happens because of the intensity of the inflammatory process during the COVID infection. The mucus plugging tends to block the alveoli that requires to be ventilated. So the alveoli is blocked, the alveoli itself is inflamed, essentially limiting oxygen transfer into the capillaries, worsening the effect of the shunt. Remember, the shunt is what we initially are driving as a concept for the oxygen, for the hypoxia and the low saturations that we pick up in these patients. Next slide. Okay. So as a result of that, we tend to have what we otherwise see on the X-ray as a ground glass appearance. These will be areas of edema or areas where the inflammation is worse. Okay, and this leaves you wondering that even if this patient actually did recover, how much lung will be available for a normal daily living for these patients. And I think that at the moment, WHO is actually, there's a thinking around long-term COVID. How do we manage these patients after they recover from ICU or after they recover from their intensive infection? Because these patients will actually require long-term care post-discharge from the hospitals. Next slide. In addition to that, because of the intensity of the inflammatory process, COVID stimulates, or the immune system stimulates the coagulation system. And I think that this was of particular concern right at the beginning of us understanding the COVID process, is that there was lots of pulmonary embolus and microembolus into the pulmonary circulation. What that does is that apart from the shunt that is already created, the impact of microemboli limits blood supply to the same alveoli that requires to be oxygenated, to the same alveoli that is inflamed, to the same alveolar capillary membrane that is edematous because of the inflammatory process, and also the impact of the mucus plugging, making these patients require huge amounts of oxygen for the available lung that is available to be oxygenated. And the huge mechanism around it is the shunt, and even that shunt is limited by the amount, is worsened by the amount of microemboli that you see. And you will see considerable amount of desaturation in these patients once you start seeing poor lung perfusion. And reduction in oxygenation that is perceived in the capillaries tends to also cause a hypoxic pulmonary vasoconstrictive process in those same alveoli, tending to worsen the shunt effect. So it means that the available lung that is there to be oxygenated will typically be what will remain in terms of alveolar dead space when we talk about ventilation. Next slide. Okay, so then we go to talking about mechanical ventilation itself. So in the initial phase of the disease process, the typical picture in terms of causing hypoxia will be a shunt. And because of the pathophysiological process of the disease of COVID, it will cause an ARDS kind of picture, or an acute respiratory distress kind of picture. And hence from the ARDS net study of 2000, we try and pick up the same concepts that we've used to manage ventilated patients with ARDS. And that targets using a low tidal volume, accepting that there will be some level of hypercapnia, because there will be poor oxygenation, and just as well, then there will be poor exhalation of CO2. There will be an element of buildup of CO2 in the capillaries. And part of the mechanical ventilatory process itself, we try and limit the peak pressures to less than 30, and also try and target a PEEP of more than 5 centimeters of water. And this is targeted by a driving pressure. So the driving pressure will essentially be the difference between your plateau pressure and your PEEP. And anything less than 15 centimeters of water in terms of difference is considered as reasonable amount of ventilation that doesn't damage the available lung that requires to be ventilated. Next slide. Okay, so this will be the picture above will almost literally be what will ideally be happening in the lung as soon as you try and ventilate these patients. So in the available lung that is there to be oxygenated, it will typically be the picture that you will see on the left side of the top picture. And once you initiate ventilation, remember the rest of the lung has been damaged by the inflammatory process. That amount of lung is not available for oxygenation. Whatever lung is available for oxygenation is where you're trying to institute lung protective ventilatory mechanisms, as indicated on the right side. Unfortunately, because it's difficult to tell how much of tidal volumes you need to place to be able to ventilate these patients. There's a risk of over distending these alveoli, because the rest of the available lung has a mucus plugging. The alveolar capillary membrane is edematous, and then there's poor oxygenation causing vasoconstriction in the capillaries. And what is available, the available lung for ventilation, will tend to be over distended, might overly be distended by the ventilatory strategies that you institute. Next slide. Okay, so inadvertently, I think this is a summary of the pathophysiological process of COVID, the understanding around ventilation, respiratory physiology, and also the understanding around ventilation. So initially, as right from the beginning, we talked about a right to left shunt causing the hypoxia. This tends to be worsened when there's microemboli into the pulmonary circulation. And then when you try to institute mechanical ventilation, you have limited amount of available lung that is there to oxygenate. That can be worsened, or that can be pushed towards an alveolar dead space picture, worsening your hypoxia or worsening your saturation. And because there's little available lung to oxygenate, in trying to avoid over-distending the available alveoli for oxygenation, you try and target lower tidal volumes, okay, which makes it difficult to actually oxygenate these patients and be able to adequately perfuse the lungs, the tissues. Next slide. Okay, so this slide is there to capture the ideas around intubation itself. Okay, so there's been kind of trying to find a middle ground. I think that when we initially started seeing COVID patients, there was an idea of saying, should we intubate these patients early? Okay, but I think some indicators showed that the outcomes were still not favorable. And then there was a next concept of trying to say, should we delay as much as possible the intubation process? So delaying the intubation process will give you the clinical picture I've been trying to describe, is that by the time you delay intubation so much, the respiratory reserve of these patients will be limited or none at all, okay? And their compensatory mechanisms would have almost been exhausted. So these are patients who will come very tachypnic. These are patients who come with very low blood pressures. And because the intubation process itself is being done in a hurry, kind of, because you want to institute adequate oxygenation, there's usually poor evaluation of the airway, okay? Creating a scenario of almost a difficult airway scenario. There's also an idea that the PPE that people put on tends to make the procedure itself clumsy. And then there's also psychological pressure because intubation is an aerosol generating process around infecting staff or the idea of cross-infection. Then because these patients are usually very sick as well, the strict infection and traffic control around the process tends to limit what you get when you're intubating these patients. So delaying intubation until there's overt desaturation, there's the very high heart rate, the patient is now tending towards hypotension, tends to also again be associated with very poor outcomes. So you have a patient that has an exhausted respiratory reserve, an intubation process that is likely to be compromised, inadvertently giving a poor prognostic picture for a patient that will actually be intubated. Next slide. Okay, so now given the picture I've given, I think the next question will be then, how can we do better? How can we do better? Where is the middle ground? When is it appropriate to intubate this patient? I think that still remains a very difficult question to answer. However, in the immediate phase, I think there's need to not delay intubation way far down the line until it's almost like a totally last resort to do. And then we need to plan around the idea of the intubation process itself. Okay, there should be an experienced practitioner to do this intubation process. Aside from that, intubation should not be planned as a last resort, such that it's a hurried process. It should be planned in advance so that there's adequate airway assessment and planning around the intubation process itself. When you actually do the intubation process, ensure that the patient is adequately oxygenated with 100% oxygen, knowing that there's little available lung that is available for oxygenation, and also planning around the drugs and positioning of this patient. Remember, because of the strict infection prevention, unless for kind of open ICUs, it limits how much help you can get when there's something that goes wrong around the intubation process. And the target of all of this is that you want this intubation to take place within at least a minute of starting the whole process, because once there's a significant delay, whatever available lung is there, there's considerable atelectasis that is going to happen. That is actually going to worsen the hypoxia around. And also it allows for people to take necessary precautions against the aerosol generating procedure and have enough hands during the intubation process. Next slide. Okay, when you actually do intubate the patient, there are other strategies that need to be considered around the mechanical ventilatory process itself. Okay, and one strategy that requires to be done is what is considered as prone positioning, and this has been done for patients that have refractory hypoxemia. And refractory hypoxemia will essentially be protracted PF ratio of less than 100 millimeters of mercury, regardless, no matter how much FiO2 or no matter how much oxygen percentage you give high up. Okay, and from research, reasonable amount, or what has been studied, is that prone positioning tends to improve oxygenation and reduce mortality when it is done at least more than 16 hours. Okay, now prone positioning can be a cumbersome process in ICU. It's not as easy as just saying let's prone the patient. It requires lots of hands, and there's a high risk of things, the IV fluids disconnecting, the airway disconnecting, losing the airway during the process of doing the actual procedure. Okay, other things that are worth considering while you've intubated and mechanically ventilated the patient is appropriate use of muscle relaxant and adequate sedation to reduce the amount of patient ventilator desynchrony that will end up worsening the damage to the available lung that is there to oxygenate. Next slide. Okay. So now, what alternatives are available for us before we reach the step that we need to intubate? What non-invasive modalities can we use? Okay, if those fail, then we go to intubation. If intubation fails, what other modality is available for us to oxygenate this patient and save a patient's life? Okay, so the non-invasive respiratory support strategies that are attractive options to avoid the need for mechanical ventilation include things like CPAP, or using a helmet, using high flow nasal oxygen. However, there's been concerns regarding these strategies. Just move down the notes for me, Vusi. Okay. Okay. So the concerns around this are that adopting these non-invasive strategies tends again to delay the intubation process, as people hope that maybe the patient will pick up tomorrow. So let's delay and see how far the patient can go. However, taking that route tends to decrease the respiratory reserve of the patient, such that by the time you decide to intubate, the outcome of the intubation process and the intention of the intubation process will almost always be defeated. There's also a concern around the risk of it as an aerosol generating procedures or modalities, and they also tend to kind of use a lot of oxygen, limiting how much health facilities are able to provide, or providing a resource constraint in terms of use of oxygen. Okay, next slide. Okay, so deciding on whether do you go for CPAP, do you do high flow nasal oxygen for these patients? I think that discussion is yet to be agreed on. I think WHO has recommended that whatever modality is available in the setting should be used. And then according to need, according to what is readily available, because currently there's no evidence on which one is better than the other. Okay, and some intensive care societies, I think the one in Australia and New Zealand, have also kind of agreed that what will be available to the patient will be determined by what is available at the facility, and also what can be done at the facility, and the resource availability to be able to provide whatever modalities is there. And one of the modalities that is kind of increasing in terms of popularity is high flow nasal oxygen. So with high flow nasal oxygen, you're able to give higher flows of oxygen, about 20 to 60 liters per minute. Okay, these are huge amounts of oxygen in terms of consumption. The benefits of high flow nasal oxygen is that it tends to give humidified and warm gases or warm oxygen. It's been thought to reduce the work of breathing, and also lessens the problems of thickened secretions and nasal irritation, and patients tend to tolerate it better. Next slide. The other alternative is CPAP. Okay, so CPAP essentially provides a positive pressure, a continuous positive pressure across the respiratory cycle. Okay, and it's been thought that it also tends to reduce the risk of needing intubation. In terms of high flow nasal cannulas, some studies have indicated that it reduces the need for mechanical ventilation by about 15%. There's nothing yet that has come up on CPAP. However, I think in the UK, there's a recovery trial that is underway, that is looking at CPAP and high flow oxygen. It's more of a registry. And currently, I think they are up to almost, I think, 12,000 patients. Nothing yet has been decided, but that will guide us in terms of which one is the better modality in terms of oxygenation before you require intubation for these patients. Next slide. Okay, so the last option, okay, all the other modalities require you to ventilate and oxygenate the alveoli, and that you have an available interface between the alveoli and the capillaries to oxygenate the capillaries. Okay, ECMO tends to bypass that process. Okay, ECMO there's typically two modalities that are available. There's veno-venous ECMO, and also there's veno-arterial ECMO. What is usually used for COVID patients is veno-venous ECMO, and this is done in almost 90% of patients. It's essentially used to rest the lung to be able to oxygenate the tissues peripherally through a vein. Okay, and there's guidelines that were published in May this year. Just go down for me, Vusi, on the notes. That were published earlier, in May this year, that indicate that there's still limited data in usage and mortality since the pandemic started. So we are still not yet sure how much ECMO will impact how we manage COVID patients moving forward. And the registry reports an estimated cumulative incidence of in-hospital mortality and at 90 days after initiation of ECMO at about 37.5%. Remember, even up to now, I think some ICUs still report 100% mortalities on institution of mechanical ventilation. And I think the first slide that I indicated showed a case fatality rate of about 45%. So which one will actually be better off is things that we're still exploring and trying to find out how do we better answer this question. Mechanically ventilating COVID patients, how do we get it right? Okay, next slide. Okay, that was all from me. References I can give on request. Other than that, I'll invite questions from the audience. Thank you very much.
Thank you very much, Dr. Munsaka. Thank you for that great review. At this juncture, we're happy to take questions. I think you've covered quite a lot of areas from physiology to the different modalities that are available at the moment. So firstly, there was a question, I think, that was shared, the question that was emailed, and that is how do we conserve oxygen? I think there is a concern, worldwide, even at Sekitumile, this side of the tertiary hospital. At some point, we were having troubles with not only oxygen but pressures. Luckily, we have our own concentrator, but we've had incidents where the concentrator actually breaks down, and we always have to try to balance that because high flow consumes quite a lot of oxygen compared to CPAP. You've spoken about the ARDS network trial, which really focuses on lung protective ventilation. We do both at Sekitumile, but I guess that question, what are your thoughts on that, conserving oxygen and those two modalities? What is your preference?
Okay, thank you very much for that question, Dr. Palai. Answering that question will be kind of multifactorial from my perspective. COVID as a disease process, I feel is one factor that we'll need to address at a community level. Okay. If we address it at a community level, we are able to reduce the numbers of patients that do come to the hospital very sick. And when they do come to the hospital, we'll have a reduced number of patients that will require oxygen. Okay, definitely there's a huge consumption of oxygen right from the modalities that I've actually indicated. High flow nasal oxygen tends to require huge amounts of oxygen flows. CPAP just as well requires huge amounts of oxygen to institute as a modality. Partly is because we have not yet found a way of clinically limiting the disease process once it sets off. Okay, so far the pharmacological management that tends to limit the need for mechanical ventilation or limit the need for high amount of oxygen is what is dexamethasone, what is recommended in the WHO guidelines, and also an interleukin-6 blocking drug. I think what is currently being used is tocilizumab. So once we are able to address COVID at a community level, I think that will be kind of the starting point. And addressing that means that we need to have governments come in terms of vaccinations. Vaccinations will be a critical factor in terms of how we are able to manage this disease process. Vaccination has been studied to be able to limit the need for hospitalization, and also limit the number of people that will require need for ICU admission, or that will require the high oxygen requirements. Unfortunately, in the current state where we are, the need for more oxygen is imperative, because that's the one modality that we need to utilize to be able to perfuse the tissues adequately and possibly save lives. Okay. So at the moment, I think that's where I think that we need to move towards. We need to limit how many people require hospitalization by increasing vaccination. And also in terms of public health, institution of those three measures that are required in terms of guidelines. Everybody should put on a mask. Everybody should social distance. And the third one, I forget the third one, but instituting those and sanitizing. Thank you very much, Dr. Palai. Instituting those modalities, including vaccination, will limit how many people we actually receive in our institution, and that will translate in a reduction in the amount of oxygen that is required.
All right.
As it stands right now, we will require that institutions be able to build oxygen plants right at the facility. Okay. And also where oxygen is required in minimal amounts, oxygen concentrators will become a very handy tool to have.
All right. No, thanks, Doc. There's another question. Thanks for that very detailed answer. It's coming from actually one of our intensivists at Second Media, Dr. Milan. What do you think about the role of assisted pressure release ventilation on refractory hypoxemia? What's your experience with that, or what are your thoughts?
Just to come again with the question.
So the role of assisted pressure release ventilation mode on managing refractory hypoxemia, which you spoke about in your presentation, and which actually Dr. Milan, who's the head of our ICU at Sekitumile, he's consistently experiencing that, and I believe he's chopping and changing in terms of ventilation strategies, given what you find on CT, from moderate to severe to getting pneumothorax to getting PE. So I think he just wants to know, what do you think the role, or what's your opinion on that?
So I'll just abbreviate this as APRV.
Yes, APRV.
The acronym standing for assisted pressure release. Yes. So APRV is usually a modality that is that we try to use for lungs that have been considerably damaged. In a sense, it functions like CPAP, like the concept around CPAP, as it provides kind of a consistent positive airway pressure right through the respiratory cycle. The idea with that is that whatever lung is available for ventilation, it should, or you don't want to lose that to atelectasis, because that will worsen the refractory hypoxemia. There's no particular ventilatory mode that has been known to be effective in terms of better oxygenation. I think what is out there is that you can try as many ventilatory modes as you are familiar with, oxygenate whatever available lung as you can. So if it's a ventilatory strategy that is available and is familiar to the physician, I think that it's worth exploring, because the lung that is available for oxygenation can be lost to atelectasis if there's no continuous positive end expiratory pressure. Yeah, that might take.
Okay, no, that's fine. Maybe I'll give him a chance to speak, but there is another question from one of our medical officers, Dr. Moyo, who would like to know about how ECMO works, because it has shown to improve mortality. I think I can maybe start, and then maybe you can take over if Dr. Moyo would like to know more. So ECMO actually, it uses very big cannulas. It's almost like dialysis, but what it really does, you put in the cannulas and you have an oxygenator which works like an artificial lung, and it adds oxygen and removes carbon dioxide. So while the patient is very, very sick, the ECMO machine or the oxygenator actually replaces the work of the lungs for that patient until the patient can actually settle or improve. So that's what it pretty much does. And it's actually the new thing, even for severe community-acquired pneumonia or very sick patients in ICU. We do have it here. It's in Bokamuso, a private hospital. Dr. Namanyane has started using that. I think it's week 5 now. He's been using ECMOs, and the machines are actually getting smaller and smaller. So I'd hope that very soon, actually, Seketumile can procure those so that Dr. Milan can start using those babies. I hope that's good enough, Dr. Moyo. Any more questions for Dr. Munsaka?
Just to I think make a correction. I'm reading the question from the chat group. He says that it improves mortality by about 35%. It's the other way around, Dr. Moyo. The mortality with using ECMO. This was done in refractory hypoxemia secondary to ARDS. The percentage is the mortality is 37%. Not that it improves mortality by that amount. No. The mortality in using ECMO is 37% when it is used as a modality to correct refractory hypoxemia secondary to very severe ARDS.
All right, thanks for that clarification, Doc. Do we have any more questions or comments from the participants? If not, it's 5 o'clock. I know some people may have more meetings. I'll hand over to Dr. Gaolathe. I believe she's on the call to wrap up for us.
Thank you, Tommy. And thank you, Dr. Effraim Munsaka, for the wonderful presentation. So we will be back again next week. The topic is yet to be determined, but please do encourage others to join. And as Tommy mentioned earlier, for some of the teams who may have missed it, it will be available on YouTube. So thank you until next Thursday.